Now we are starting with a cardiovascular system, and in this regard we are starting treatment of angina pectoris. I am Dr. Mubasherah Jamil, Pharmacology Department. Now before starting angina, we should understand what is angina. It is intermittent chest pain caused by transient irreversible myocardial ischemia. Now, what do you understand by intermittent? Means off and on. And what do you understand by transient? Means for a short period of time. And what do you understand by reversible? Means something which can be reversed back to its normal. Now, what kind of pain and where is the pain? The pain is always substernal, and usually it is relieved by rest or by taking anti-anginal drugs, predominantly nitrates. The name angina pectoris denotes chest pain. And how does it is caused? It is caused by accumulation of metabolites resulting from the myocardial ischemia. Now, what do you understand by ischemia? It is the lack of oxygen to the myocardial tissue. Now, what is the cause of angina? It is the atheromatous obstruction of the large coronary arteries, and the disease is called coronary artery disease. Now, what is atheromatous obstruction? Atheroma is when the clot forms, then we call it atheroma. Now, the other reason is inadequate blood flow in the presence of coronary artery disease, which results in effort angina, also known as classic angina, as we all know. Now, another condition is transient spasm of the localized portion of these vessels, and this can also cause myocardial ischemia and pain. So, what is the conclusion? The primary cause is imbalance between the oxygen requirement of the heart and the oxygen supplied to the heart via the coronary vessels. And normally, what happens that whenever myocardial oxygen requirement increases, the coronary blood flow also increases, but in this case, in angina, this doesn't happen, and the coronary blood flow does not increase proportionately. Now, there are certain other conditions in which ischemia or angina does not always represent as a pain, rather it results as a silent or ambulatory ischemia, and the only thing you notice is ECG change. Now, what is unstable angina? Unstable angina is an acute coronary syndrome, ACS, and it is said to be present when the episodes of angina occur even at rest and when there is an increase in the severity, increase in the frequency, and the duration of the chest pain also increases in patients which previously have stable angina. Means before unstable angina, you go through the condition of stable angina. Further, I will explain to you what is the difference between stable and unstable. Now, we will understand the basic things and the basic pathophysiology of angina. So, we categorize it in three different headings. Determinants of, the first one is determinants of myocardial oxygen demand. Means if you are saying that the basic problem in angina is between oxygen supply and oxygen demand, then what are the determinants which determine the myocardial oxygen demand? Now, what are the determinants when there is an increase in the heart rate, increase in the contractility, increase in arterial pressure, or increase in ventricular volume? All this will increase the oxygen demand of the heart. Now, all the drugs that reduce all these determinants can reduce cardiac oxygen demand. Now, another thing is usually what happens that oxidation of fatty acid require more oxygen per unit of ATP generated than oxidation of carbohydrate. Now, heart usually favors fatty acids as a substrate for energy production. Therefore, the newer anti-anginal drugs They shift myocardial metabolism toward greater use of glucose, rather fatty acid, to reduce the oxygen demand without altering heart rate, blood pressure, or contractility. Now, the other thing is determinants of coronary blood flow and myocardial oxygen demand. Now, what is coronary blood flow? All the blood vessels which supply the heart are coronary blood vessels. Now, coronary blood flow is directly related to aortic diastolic pressure and duration of diastole. The other thing, the coronary blood flow is inversely proportional to coronary vascular resistance. Now, what does this mean? More the aortic diastolic pressure, more the duration of diastole, means you have more blood flow in coronary vessels. Less the coronary vascular resistance, less the coronary vascular resistance in the coronary vessels, there will be more coronary blood flow, right? The third thing is determinants of vascular tone, means fiber tension, Now, usually what happens, arterial blood pressure determines the systolic wall stress and the venous tone determines the diastolic wall stress. They both play a role in determining myocardial wall stress. Now, arterial tone directly controls the peripheral vascular resistance and arterial blood pressure. In systole, what happens? Intraventricular pressure must exceed aortic pressure to eject blood. So, under the heading of determinants of vascular tone, you will remember two basic things. Arterial blood pressure determines the systolic wall stress, and venous blood pressure, venous tone, determines the diastolic wall stress. This is the figure from your book, Edson, and this shows what things increase the intramyocardial fiber tension and ultimately myocardial oxygen requirement. So we will start from the diastolic factors. There are two diastolic factors, blood volume and venous tone. Means more the blood volume, more the venous tone, more fiber tension, and the heart will require more oxygen. Now just come to the systolic factors. There are four systolic factors: peripheral resistance, heart rate, heart force, and the time it takes during ejection of the blood, ejection time. All these also increase the fiber tension or muscular tone. So all these factors contribute to myocardial oxygen requirement. Now, after having said all the pathophysiology, now depending upon the pathophysiology, we classify types of angina before classifying anti-anginal drugs. So there are different types. Typical, which we usually see, is stable angina. Then princemetal or variant angina. The most common cause of coronary artery disease, the unstable angina. Another name is crescendo angina. Now there is other forms of angina, angina with normal coronary arteries and microvascular angina, and there are different pathophysiologies related to each kind of. Now we will see a short definitions of these types of angina. What happens in classical angina? It is due to atherosclerosis of the coronary arteries. What is variant angina? It is due to transient coronary vasospasm, means the coronary arteries contract for a short period of time. Now comes to the unstable angina. This is what is. It is progressive occlusion of the coronary artery. Progressive occlusion means before coming to the stage of unstable angina, the patient have already been gone through classical angina or stable angina. Now what happens in classical angina? There is only plaque formation, but it has not been disrupted. But in unstable angina, the fibrous cap ruptures and the blood comes to attach with the atheroma and plaque forms, atherosclerotic plaque forms, platelet aggregation occurs, and rupture of the atheromatous plaque happens. In this figure you can see the progressive, this is what is called progressive occlusion and thrombus formation. So now you can see here, at this stage there is a rupture of the fibrous cap, and now blood is coming to attach with the atheroma, right? Now here, now it is progressively occluding the artery as well. So these three stages come under the stable angina. Now when complete occlusion leads to unstable angina and myocardial infarction, collectively we call it as ACS, means acute coronary syndrome. Now start looking at here. This is coronary artery disease. Plaque is going to build up. This is plaque, right? Now come here. This is also plaque. This is also plaque. Now there is narrowing of the arteries, and now it is harder for the blood to get through the artery. How heart attack occurs? There is complete occlusion. Plaque cracks, ruptures, and blood clot blocks the artery. So here you can see also the difference between stable and unstable. What happens in stable? The vessel is unable to dilate enough to allow adequate blood to meet the myocardial oxygen demand. And what happens here? Partial occlusion of the vessel, as you can see. Angina occurs even at rest. And here you can see ECG changes. Stable angina shows normal ECG, and unstable angina will show you either normal, inverted T wave, or ST depression. The other form of angina we were talking about is Prinzmetal angina, and it is due to transient coronary artery narrowed or spasm. Now, what is the goal of major anti-anginal drugs? Like, what do you want to do with the heart with the anti-anginal drugs? You have four basic goals: increasing cyclic GMP, decreasing intracellular calcium, stabilizing vascular smooth muscle cell membrane, and again by increasing CGMP you increase CAMP in the vascular smooth muscle cells as well. Now what happens by increasing cyclic GMP? It facilitates the dephosphorylation of myosin light chains. Now what myosin light chains do? Whenever they overlap each other, actin myosin, they cause contraction. So by preventing dephosphorylation, what we are doing? We are preventing the interaction of myosin with actin. Now what kind of drugs do this? Nitrates. The other thing, decreasing intracellular calcium. Now why we are worried about calcium? What does calcium do? Normally, for any kind of interaction of myosin and actin, we need intracellular calcium. So by using calcium channel blockers, they predictably cause vasodilation because they reduce intracellular calcium, and calcium is a major thing required for the activation of myosin light chain kinase. Beta blockers and calcium channel blockers, they both reduce calcium influx, thereby reducing all the three parameters: rate, contractility, and oxygen requirement under most circumstances. The third thing is stabilizing vascular smooth muscle cell membrane. The membrane potential of the excitable cell is stabilized near the resting potential. How? By increasing the potassium permeability. So, another form of drugs can be potassium channel openers, such as minoxidil sulfate, increase the permeability of potassium channels. By increasing CGMP, we are also increasing CAMP. They are converting GTP into cyclic GMP. Now what is cyclic GMP is doing? It is going to react with cGMP dependent protein kinase, and what does it will do? It will do the phosphorylation of myosin light chain. So phosphorylated myosin causes contraction and dephosphorylated causes relaxation. So what are our principal therapeutic goals of the anti-anginal drugs? We will decrease preload, we will decrease afterload, we will decrease heart rate, and we will dilate the coronary artery. So different drugs for different purposes. To decrease preload, we have nitrates and potassium channel openers. To decrease afterload, we have calcium channel blockers and potassium channel openers. To decrease heart rate, we have again beta blocker and calcium channel blocker. Now coming to the classification of anti-anginal drugs, we have three major categories. We have vasodilators, then cardiac depressants, and then other drugs which are usually associated with the metabolism rate or something like that. Now under vasodilators, we have nitrates and calcium channel blockers. Calcium channel blockers also act as cardiac depressants along with beta blockers. Now coming to nitrates, we have long duration, intermediate duration, and short duration. Long duration or long acting nitrates are usually in the form of transdermal patches. Intermediate ones are usually oral, and for the short acting for which you want the immediate action are usually sublingual or spray form. Further classifying vasodilators, nitrates and nitrites. So we have to now memorize the names. Short actings are inhaled amyl nitrite, sublingual nitroglycerine, sublingual isosorbide dinitrate. Under the category of intermediate, we have oral sustained release nitroglycerine and oral isosorbide dinitrate. Under the long acting, we have transdermal patches, as you know. Now coming back to the calcium channel blockers, we have three drugs mainly: nifedipine, diltiazem, and verapamil. Again, as we have told, under cardiac depressants come calcium channel blockers as well, so the name remains same. Beta blockers are propranolol, atenolol, and metoprolol, and you will discuss beta blockers in detail under the topic of beta blockers. The newer anti-anginal drugs are fatty acid oxidation inhibitors, and we have mainly two newer drugs, trimetazidine and ranolazine. So having said all these drugs, what is the aim of our pharmacological treatment of angina is to reduce oxygen demand by the heart and to deliver more oxygen to the heart. The non-pharmacological methods are myocardial revascularization, for example bypass, for example angioplasty, right? Now coming to the first category of the anti-anginal drugs are nitrates. Now what is actually the mechanism of nitrates and nitrites? We take the drug, and what happens in the smooth muscles? The nitrates are denitrated and nitric oxide is released. What happens? As you all know, nitric oxide stimulates guanylyl cyclase. Now what does it do? You all know by now. Guanylyl cyclase causes an increase in the cGMP, which leads to dephosphorylation of myosin light chain phosphate, causing relaxation of the smooth muscle of blood vessels, and ultimately what you get a bigger diameter of the artery, a somewhat more blood flow, and relaxed arteries, right? Now you can see in this figure here, this is all same. Here what happens, these are What is the role of calcium physiologically? Normally, it causes the myosin light chain phosphorylation, and then contraction occurs. When you give calcium channel blockers, this all is blocked and relaxation of the arteries happens. Now you can see here the nitrates, which are releasing nitric oxide. What does it doing? As we have already said, that it increases guanyl cyclase, cyclic GMP, and cyclic GMP causes relaxation of the arteries. Here you can see another drug. This is another vasodilator. Now, what happens hemodynamically when you take nitrates? They act in three ways. Coronary artery dilatation. By increasing coronary artery dilatation, decrease coronary bed resistance, so vasospasm is relieved. Blood flow in the coronary vessels increase. So by increasing blood flow, what you are doing, you are increasing the oxygen supply, and this is the goal of anti-anginal drugs, to increase the oxygen supply. Now what happens on peripheral resistance? It is also reduced. If the resistance is reduced, the blood pressure is decreased, after load is decreased, workload is decreased. So this means when you all have decreased workload, you have decreased oxygen demand. This is our second goal of anti-anginal drugs. Now, what happens at the venous level? Reduced venous return because of the dilatation. Ultimately, decreased left ventricular volume, decreased preload, of course decreased workload, and of course decreased oxygen consumption. So by using nitrates, we are doing both things. We are decreasing oxygen demand and we are increasing oxygen. Now we have to look a bit the pharmacokinetics. Well absorbed, all the formulations sublingually, they have rapid onset and short duration. All the oral formulations have more prolonged and prophylactic action. The spray form or inhalation form also have rapid action, 15 seconds, 1 minute, 5 minutes. And the transdermal patches are sustained release, and usually they are giving OD doses, means 1 transdermal patch a day. Now, what about metabolism? 90% it's in liver, means it's extensive for dinitrate and tetranitrate formation. Mononitrate does not undergo metabolism, so its bioavailability is very high. Now we have the other two forms, isosorbide dinitrate and isosorbide mononitrate. What is the difference? The first one is used to reduce the frequency and severity of acute anginal episodes. Sublingually, it acts in 2 minutes, and therapeutic effect lasts for about 4 hours after oral administration. What happens with the isosorbide mononitrate? It is well absorbed after oral administration and almost 100% bioavailable. So its half-life is 5 hours. But remember that isosorbide mononitrate is used only for prophylaxis of angina. Never try to give it in acute attacks. Now the other one is amyl nitrite, and it is given by inhalational route, and it provides very rapid absorption, and like the sublingual route, it also avoids the hepatic first pass metabolism. Now it is obsolete for angina because of two reasons: unpleasant odor and short duration of action. Now, when we talk about all the nitrates, we have an important aspect of giving nitrates, that this category of drug develops tolerance. Now, tolerance is very important in the use of nitrates because it causes the stoppage of the drug ultimately. What are the reasons of the tolerance? There are many reasons proposed. One of them is decrease in tissue sulfhydryl groups. It can only be partially prevented or reversed with a sulfhydryl regenerating agent. The other one theory is increased generation of oxygen-free radicals during nitrate therapy. This also causes tolerance. Another theory proposed is the diminished availability of calcitonin gene-related peptide, which is a potent vasodilator. So it is also decreased because of the use of nitrates. So all these factors and many more contribute to the tolerance of the nitrates. Now, as you all know, with continuous exposure to nitrates, isolated smooth muscle may develop complete tolerance, which is also called tachyphylaxis, and the human becomes progressively more tolerant when long-acting preparations or continuous IV are being given for more than a few hours without interruption. What does all this mean? Then how tolerance develop? You are giving long-acting nitrates, you are giving without interruption, and you are giving, like for suppose you are giving for 4 to 5 hours without interruption. The other form of tolerance develops usually in the workers which work in any industry, any nitrate forming industry, and the symptoms they develop and the disease they develop is called Monday disease. What happens is when the contamination of the workplace is severe with the nitrates, workers find that upon starting their work, usually on the first day of the week, that is Monday, they suffer headache and dizziness. After a day or after a few days, these symptoms disappear because now they have developed tolerance. Now when the weekend comes, the exposure to the chemicals is also reduced. This tolerance disappears, so the symptoms reoccur each Monday. Means they will develop problem on Monday. The problem will decrease progressively during the week, and again in the weekend they will suffer. And on the Monday they will suffer headache and. Now there are few indirect effects of nitroglycerin, and what are those? These are compensatory mechanisms which are being evoked or stimulated by baroreceptors and hormonal mechanisms, and they lead to tachycardia and increased cardiac contractility. These indirect effects and these reflex effects by baroreceptors also contribute to the development of tolerance. Now, the actions on the smooth muscle organs. What happens? Relaxation of the smooth muscles of the bronchi, GIT, and genitourinary tract has been demonstrated, but there is no clinical use related to the role of nitrates in smooth muscle organs. Now, what is the action on platelets? Nitric oxide released from nitroglycerin stimulates guanylyl cyclase in platelets as well as in smooth muscle. The increase in cGMP is also responsible for a decrease in platelet aggregation. Now there are other few effects of the nitrite ion. What happens? It reacts with the hemoglobin and it produces a kind of hemoglobin which is called methemoglobin, which contains ferric ion. Now, as compared to hemoglobin, methemoglobin has a very low affinity for oxygen. Large doses of nitrites can result in pseudocyanosis or tissue hypoxia, and in severe cases death as well. But fortunately, even if you are giving large doses of organic and inorganic nitrates, they does not cause significant methemoglobinemia in adults. But this aspect of the nitrates is being used in a certain condition, which is cyanide poisoning. Now what happens in cyanide? Cyanide poisoning results from complexing or mixing of cytochrome iron by the cyanide ion. Now methemoglobin iron has a very high affinity of this cyanide ion. Thus, administration of sodium nitrite soon after cyanide exposure, what does it do? It regenerates the active cytochrome. So, methemoglobin produced can be further detoxified by giving sodium thiosulfate, and this results in the formation of thiocyanate ion. Now, this thiocyanate ion is less toxic ion and it is readily excreted. So, if side by side, if methemoglobinemia is occurring, so this can be treated by giving methylene blue intravenously. This antidotal procedure is now being replaced by another drug. Now, under the headings of what does nitrates do as an anti-anginal drug in different scenarios of angina or in different types of angina. So, what nitrates do in the angina of effort? Decrease venous return, reduction of intracardiac volume, and ultimately arterial pressure, decreased intraventricular pressure and left ventricular volume, decreased wall tension means fiber wall tension, decreased myocardial oxygen requirement, overall decreased coronary blood flow. What happens in variant angina? Nitrate benefit patients with variant angina by relaxing the smooth muscle of the epicardial coronary artery and relieving that transient coronary artery spasm. Now, what does nitrate do in unstable angina? Nitrates exert their beneficial effects both by dilating the artery and by reducing myocardial oxygen demand. Nitroglycerin also decreases platelet aggregation, and this effect is very important in unstable angina. This is the table from the Ketzing as well, and it reads the potential beneficial effects and the potential deleterious effects of the nitrates. So, by decreasing the ventricular volume, arterial pressure, ejection time. What are we decreasing? We are decreasing myocardial oxygen requirement. Now, by increasing the vasodilation and the collateral flow, what we are doing? We are doing increased or improved perfusion to the ischemic myocardium, and we are relieving the coronary artery spasm, and we are improving the subendocardial perfusion. Now, what are the effects which we don't want and which are very potential deleterious effects are reflex tachycardia. These are the reflexes caused by baroreceptors, and reflex increase in contractility, and decreased diastolic perfusion time due to tachycardia. But all these potential deleterious effects are being balanced by giving beta blockers. We are going to elaborate it further. What are the adverse effects of the nitrates? The most common one is headache. The others are hypotension, facial flushing, and tachycardia. Now there is a drug which is contraindicated, sildenafil. Why it is contraindicated? Because it potentiates the action of nitrates and dangerous hypotension may occur. So this combination is contraindicated. Here you can see, if you are giving both these drugs together, they both cause increase in cyclic GMP. By increasing cyclic GMP, as you can recall, we are relaxing the arteries and we can cause hypotension. Now there are one of the drug which comes under the category of other nitrovasodilators, and the name is nicorandil. It is a nitrate ester that has vasodilating properties in normal coronary arteries. It reduces both the preload and the afterload, and it also provides some myocardial protection. How? By preconditioning and by the activation of cardiac potassium ATP channels. So here we end the first category of drugs, anti-anginal drugs, nitrates. Okay, so in short, if we summarize what we are doing by nitrates, we are increasing oxygen supply and we are decreasing the oxygen requirement. Now the other category are the calcium channel blocking agents. To recall, what is the role of calcium? Transmembrane calcium influx is necessary for the contraction of smooth and cardiac muscle. So the blockers which are available are exclusively L-type calcium channel blockers, and they inhibit the calcium influx. So there is no excitation contraction coupling. In this figure you can see the normal role of the calcium channels. This you have seen previously as well. Because of the entry of the calcium, we have this phosphorylation and we have actin-myosin cross-bridge, and here you can see this is the contracted state of the vessel, and this is also the contracted smooth muscle. This is relaxed, this is contracted. Now what happens when we give calcium channel blockers? This you can see calcium, and this is the compartment containing internal calcium stores. This is calcium channel, and by giving calcium channel blockers we are preventing, this is calcium guys, and we are preventing calcium entry where? Into the cytosol of the cell, and ultimately heart muscle cell does not respond to calcium ion signal. Now we have to classify calcium channel blockers as well. So we have mainly three categories: dihydropyrimidines, phenylalkylamines, and benzodiazepines. Dihydropyrimidines have three generations: first, second, third. First generation have nifedipine, estradipine. Second generation have nicardipine, and the third generation most commonly used amlodipine and feldipine. The phenylalkylamines have the major drug, prototype drug, verapamil, and the benzodiazepines have diltiazem. What is the mechanism of action of calcium channel blockers? Of course, by having said that it is a blocker, so what is it is doing? It is blocking the calcium channel. So normally what happens, as you all know, in vascular smooth muscles, entry of calcium through L-type calcium channel occurs, and it leads to activation of MLCK, which then leads to phosphorylation, finally resulting in actin-myosin cross-bridging and contraction. By giving calcium channel blocker, we are inhibiting all this process, resulting in vasodilation. Now what happened in cardiac cells or myocytes? Decrease calcium entry through L-type channels. This leads to decrease in myocardial contractility, SA node pacemaker rate, and also the atrioventricular conduction velocity is also decreased. This is the same thing which you have seen in previous books and previous figure, and you have this in cancer. Here you can start looking at this calcium channel. Normally this happens. This is the normal process until contraction. Now by giving calcium channel blockers, you are inhibiting all this, and by inhibiting all this, what happens? Dephosphorylation of MLCK, and you have a relaxed blood vessel. So more blood supply, less workload. So calcium channel blocker block voltage gated L-type channels, and these drugs bind more effectively to open channels and inactivated channels, thereby reducing their frequency in response to depolarization, ultimately causing decrease in transmembrane calcium current, and this causes decrease in contractility throughout the heart and decrease in sinus node pacemaker rate and AV nodal conduction. Usually, calcium channel blockers act from the inner side of the cell membrane and bind to the calcium channels in depolarized phase and block the entry of calcium inside the cell. This inhibits excitation contraction coupling completely in smooth muscles and in cardiac cells. And in this slide, we are explaining again the same thing, that impulse in SA node and AV node, they are all dependent in calcium influx. So by giving calcium channel blocker, this is reduced or blocked by all the blockers of the calcium channels. So ultimately, these drugs reduce cardiac contractility in a dose-dependent fashion. Okay, this reduction in cardiac mechanical function is another mechanism by which the calcium channel blockers reduce the oxygen requirement in patients with angina. Now, calcium channel blockers have effect on vascular smooth muscle, on cardiac muscle. So we will see separately what happens in smooth muscle. Vasodilation of systemic arterial smooth muscle occurs, and this causes decrease in systemic blood pressure. Vasodilation of coronary arterial smooth muscles, what results in that? Increased blood supply to cardiac muscle. So what we are getting the net result? Decreased blood pressure and increased blood supply to the cardiac muscle. Now what happens in cardiac muscle? At the level of SA node, there is decreased rate of nodal discharge. At the level of AV node, there is decreased AV conduction. Ultimately, decreased heart rate, myocardial contractility, and decreased conduction. Here you may have question, what are the effects of calcium channel blockers or at different levels of cardiac muscle? So you have to memorize. What happens in skeletal muscle, or what is the effect of calcium channel blocker on skeletal muscle? Skeletal muscle is not depressed by the calcium channel blockers. Why? Because it uses intracellular pools of calcium to support excitation contraction coupling rather than the extracellular, and it does not require as much transmembrane calcium influx. Now what happens in cerebral vessels? Cerebral vasospasm and infarct following subarachnoid hemorrhage. So there is a drug, nimodipine, member of dihydropyrimidine group. It has a high affinity of cerebral blood vessels and it appears to reduce morbidity after a subarachnoid hemorrhage. So if we have a condition of cerebral vasospasm and subarachnoid hemorrhage, then we have a calcium channel blocker, nimodipine. Okay. This is the mechanism of clinical effect of all the calcium channel blocker collectively. Now we will start looking at this point. Now calcium influx is inhibited. We have three things here. Vascular smooth muscle contraction is inhibited. Left ventricular contraction heart rate is decreased. And this is SA node automaticity is decreased. AV node excitation is decreased, conduction is decreased. Now when we have decreased vascular smooth muscle contraction, we have dilatation, peripheral vessel dilatation and coronary artery dilatation. If the peripheral vascular resistance, by dilating the peripheral vessels, we are decreasing peripheral vascular resistance, ultimately decreasing the blood pressure, and after load, this means one of the aim has been achieved, that is oxygen consumption in myocardium is now decreased. Okay, now by causing coronary artery dilatation, what we are doing, we are increasing the coronary blood flow, and by increasing the coronary blood flow, we are achieving the second target, and that is increased oxygen supply in myocardium, and this is the main goal of angina treatment. Now coming here, this kind of the response of calcium channel blockers regarding AV node and SA node, this is used in arrhythmias. Now we will touch a little bit of pharmacokinetics of calcium channel blockers. Coming to absorption, typically oral form, but verapamil and glutathione also have IV forms as well. They all possess significant first-pass metabolism, means there is not 100% bioavailability in oral form. Now metabolism and excretion, it is excreted by kidney, the two of the drugs, nifedipine and verapamil, and verapamil is also excreted by the liver as well. Now there is a term called coronary steal syndrome by nifedipine. What happens in this? The rapid onset of action, that is less than 20 minutes, produces precipitous fall in blood pressure, means it produces rapid fall in blood pressure. So what happens? Drug induced hypotension occurs and it triggers severe reflex tachycardia, which can even worsen the condition of MI or myocardial ischemia. How? By increasing the myocardial oxygen demand and decreasing the myocardial oxygen supply. Status. Now we have different calcium channel blockers, so we have to see which type of drug is given in which type of condition. So what is the status? Now we have the nifedipine and amlodipine. It is significantly used for arteriolar vasodilation and it has little effect on cardiac tissue, so it is more used in systemic hypertension. Nifedipine has more vasodilation effect, which can even lead to reflex tachycardia and can precipitate angina or coronary steal syndrome. Amlodipine is more useful as an antihypertensive agent. This newer drug is recently approved only IV and it is also used in hypertensive emergencies. These two drugs, verapamil and diltiazem, they have more effect on heart than in the vascular smooth muscle. They cause decreased automaticity of the heart, decreased conduction velocity, and decreased contractility. So this response is basically used in angina due to cardiac depressant action. What are the different uses? Calcium channel blockers are used as an antiarrhythmic drugs, as an anti-anginal drugs. What kinds of angina? Exertional angina, unstable angina, angina due to coronary spasm. Now, it is also used in systemic hypertension and certain kind of arrhythmias, atrial fibrillation, flutter, and paroxysmal supraventricular tachycardia. Now, the other therapeutic uses of dihydropyrimidine groups is exertional angina, unstable and Prinzmetal angina, hypertension. In vessels is Raynaud phenomena, and in a certain condition called preeclampsia. Now, what are the other uses? As we have already said earlier, in cerebral vasospasm and in subarachnoid hemorrhage, and up to some extent it is also used as an uterine relaxant. There are of course certain adverse effects of the calcium channel blockers, but they are the extensions of their pharmacological actions. What does it mean? It means their action, if exaggerated, if increased, cause adverse effect which you don't want. And what is it? This is flushing, common with nifedipine, constipation, common with verapamil, and the major side effects are heart-related, bradycardia, AV block, heart failure, but these are all because of the extensions of the negative chronotropic and inotropic effects. Now, usually the problem comes with the short-acting calcium channel blockers because of their prompt release. Nifedipine have the potential to enhance the risk of adverse cardiac events and should be avoided. This means if you are prescribing calcium channel blockers, look for long-acting. And if you are prescribing calcium channel blocker plus beta blocker, it will have more cardiodepressing effect as well, so you have to watch out. In patients with unstable angina, the immediate release short-acting calcium channel blocker can increase the risk of cardiac events, so these are contraindicated. If we try to think in our mind that what is the major difference between calcium channel blocker and beta blocker, so the key difference between beta blocker and calcium channel blocker is the beta blockers, they inhibit the action of hormones epinephrine and norepinephrine by blocking the binding of these hormones into beta adrenoceptors. Now, as you all know, what are beta receptors? Beta receptors are receptors located by the cells which are innervated by the sympathetic nervous system, and we have three types of beta receptors: beta 1, beta 2, and beta 3. Beta 1 is in heart, beta 2 is in lungs, and beta 3 in adipose tissue. Now, the calcium channel blocker, on the other hand, disrupts the movement of calcium ions through the calcium channels. So this is the major difference. beta blocker, it is dealing with the hormones. And calcium channel blocker, it is dealing with the calcium ions. Now we are going to read the third category of anti-anginal drugs, which are beta blockers. How do they work? They work by blocking the effect of adrenaline or epinephrine or norepinephrine on the heart. By blocking these hormones, we have two conditions. We are slowing the heart rate and we are decreasing the force of heart muscle contraction, and both of these things reduce the amount of oxygen required by the heart, and by giving beta blockers we achieve this target of anti-anginal drugs. Now beta blockers have few beneficial effects and few non-beneficial or undesirable effects. Beneficial effects which we are using as an anti-anginal treatment are decreased heart rate, blood pressure and contractility, which ultimately decrease myocardial oxygen requirement at rest and during exercise. Now, the heart rate is also associated with an increase in diastolic perfusion time that may increase also the coronary perfusion as well. We have said earlier that there is one kind of ischemia which is silent, which does not give pain. So beta blockers are also beneficial in treating silent or ambulatory ischemia as well. Remembering what happens in the silent one, there is no pain, there is only ECG change. The total time period of the ischemic time per day is reduced by giving beta blockers in this condition. Now coming to the untoward effects which we don't want are increase in end diastolic volume. Now an increase in ejection time. So what you see? Increase in end diastolic volume and increase in ejection time. And both of these increase the myocardial oxygen requirement, and this is what we don't want in angina. But when we give beta blockers along with nitrates, these undesired effects are balanced by the nitrates. Here at different level you can see what beta blockers are doing. They are inhibiting some cardiac functions. At the level of SA node, slows down SA node responsible for initiating heartbeat, so ultimately reducing heart rate. Increases AV node refractoriness, slows the response, ventricular response to atrial fibrillation and atrial cardia, so ultimately it is slowing the conduction. By dilating the main artery, it is lowering the blood pressure. At the level of ventricle, reduces myocardial contractility and cardiac output, ultimately reducing contractibility. At the level of ventricular muscle, also reduces contractibility. So when we are coming to the classification, we have major three kinds of beta blockers: non-selective, beta 1 selective, and both alpha and beta blocking activity. So non-selective are further classified into drugs which have intrinsic sympathomimetic activity, means they act as partial agonist, and with or without intrinsic sympathomimetic activity. So without intrinsic sympathomimetic activity are nadolol, propranolol and timolol. The other category includes the major drug pinzolol. Now again, beta 1 selective which don't have intrinsic sympathomimetic activity are atenolol, bisoprolol, esmolol, metoprolol and nebivolol. The other category contains acebutolol. Now the drugs which have both alpha and beta blocking activity is carvedilol and levetolol. Beta 1 selective blockers, they are used only for prophylactic therapy of angina. They are of no use in acute attack. So whenever you are giving beta blockers as an anti-anginal drugs, you are not giving an acute attack, you are giving for the long-term treatment. It is also effective in preventing exercise-induced angina. but in vasospastic angina or pinch metal angina, it is not effective. Now, the cardioselective beta blockers such as metoprolol or atenolol are more preferred, thus propranolol is less preferred. Now, what are the effects of non-selective beta blockers? The most important effects are on serous and bronchial smooth muscle. They competitively block the effects of norepinephrine on beta 1 and beta 2. Some of them exhibit intrinsic sympathomimetic activity and membrane stabilizing, that is also called local anesthetic effect. Blockage of beta 1 receptors and the blockage of beta 2 receptors occur. Now, where we are going to prescribe beta blockers other than angina? Atrial fibrillation, cardiac arrhythmias, congestive heart failure, hypertension, mitral valve prolapse, myocardial infarction. Adverse effects, bronchoconstriction. So, always contraindicated in bronchial asthma or COPD. Arrhythmias. So, beta blockers should be stopped gradually, not immediately, not abruptly. Bradycardia and cardiac depression occurs. There is also some incidences of cold extremities, insomnia, depression, fatigue, disturbances in metabolism. So special care have to be taken in diabetics. Now there are certain drug interactions where the beta blockers have interactions with cimetidine, fusimide, chlorpromazine. What kind of interaction? They may potentiate the antihypertensive effect. Now, there are few drugs which can reduce its effects, and these are barbiturates, phenytoin, and rifampicin. When we are giving nitrates and beta blockers combined, both of them balance their undesired effects. Beta blockers prevent reflex tachycardia and contractility produced by the nitrates, and nitrates prevent coronary vasospasm produced by the beta blockers. So we have more benefits in giving them together. Nitrates prevent increase in left ventricular filling pressure or preload, resulting from the negative inotropic effect produced by the beta blockers. So this effect is also being balanced. Nitrates and beta blockers both reduce myocardial oxygen consumption by different mechanisms, as we have all studied now. So both of them increase subendocardial blood flow by different mechanisms. Now, here you can see the comparisons. One of them, start looking from the nitrates. If heart rate is increasing, the beta blocker is causing decrease. If the contractility is increasing, the beta blocker is decreasing the contractility. In everywhere you can see up till here that there is being balance between the effects of these two drugs. Now coming here, oxygen consumption. Now we have the major target achieved, that is moderate decrease in oxygen consumption, and this is the target of anti-anginal drugs. Now, up till now, we have read three classes of drugs: nitrates, calcium channel blockers, and beta blockers. Now we have some newer anti-anginal drugs: ranolazine, trimetazidine, and ivermectin, and they act by different mechanisms. Ranolazine acts by reducing a late sodium current that facilitates calcium entry. So by reducing it, we are reducing the calcium influx. We have talked earlier about the fatty acid oxidation, which uses more oxygen consumption. So by giving this fatty oxidation inhibitors, we are decreasing the oxygen consumption or oxygen requirement. Now there is other kind of bradycardic drugs, selectively IF sodium channel blockers, ivermectin. It inhibits the hyperpolarization activated sodium channel in the sinoatrial node. So ivermectin is also used to improve anginal attack with an efficacy similar to that of calcium channel blockers.